Assalamu alaikum. It's very nice to be back always in Qatar. And I thank, of course, the organizing committee for accepting this abstract. And this is work done by myself and my colleagues in Cairo University Children's Hospital. And I'm going to present comparison of percutaneous closure of small PDA by detachable coils versus the new Amplatzer duct occluder 2. This is our hospital, Cairo University Hospital. It's in 1985 it was opened, but this is Cairo University itself, which is more than 100 years old. So transcatheter closure of a patent ductus arteriosus is currently a reliable alternative to surgery. Non-surgical closure of PDA was first introduced in 1967, so it's an old procedure. And detachable coils, as we all know, are the line of choice for transcatheter closure of small PDAs. The Amplatzer ADO1, or the Amplatzer duct occluder, the usual one, by AGA, has become a safer and more effective technique, method of closure, especially in larger PDAs. In this report, actually, we compared the safety and efficacy of the Amplatzer duct occluder 2, which was introduced by AGA, in Cairo University Hospital. So we had 63 patients, and the mean diameter, they are all small PDAs, 2.4 millimeter in the whole group. 20 patients had the Amplatzer duct occluder 2, 39 patients had the coils. There were two who had very small PDAs that we could not cross, and there were two who had the arteriovenous loop, which was done before the introduction of the Amplatzer duct occluder 2. We all know the classification of PDAs by Krishenko, the 5 types, and our group, 2 groups were similar in this classification, mostly in the type A or conical PDAs. I just want to show you this tiny PDA. Most of cardiologists will just leave it alone, especially that it's not causing any hemodynamic effect, or maybe it's a silent PDA, and we'll just leave it and tell the patient to go away with it. However, this, or actually it was another patient, not this particular echo. I had a patient who was 7 years old, and his mother was a pediatrician, and she was obsessed with this tiny PDA. She had 2 catheters, and each time the doctor will go there, tell her it's like a thread-like, just go away. And she goes to another doctor who does another catheter, and she had 2 catheters and she didn't have it closed. And she goes to every meeting everybody, asking about this tiny PDA. So sometimes you need to close these tiny silent PDA, and actually when I looked into the literature, there were many reports, especially recently, about closing a very small and tiny PDA, and I quote this, which was published in 2007, Cardiology in the Young: the decreasing incidence of morbidity and mortality with intervention, combined with the serious consequences associated with an episode of endocarditis, makes the risk of an intervention an acceptable alternative. For many parents, this concept is a very important consideration, and from this perspective, the risk of closure is a singular event where all the risk is peri-procedure and immediate. From both our perspective and that of the parents, this singular intervention avoids the uncertainty associated with the possibility of unpreventable episode of endocarditis in the individual with PDA. So people are going more and more towards closing small and tiny PDAs. Of course, we all know the detachable Cook coils, and they are made of stainless steel with hemostatic fibers embedded through the length of the coil and can be retrieved and repositioned. They have a screw here if needed. This is the PDA we're talking about. A lot of our patients had very tiny PDAs, and it's very easy to put a coil there and close this PDA. However, also when we review the literature, there is significant complications with coils like hemolysis and or embolization. Of course, these complications are much less with smaller PDAs, but they are still reported. And when we review the literature even more, I found this embolization rate which was really significant. Of course, it is more when the PDA is 4 millimeter, a large PDA, but it's still a considerable embolization rate up to recent reports. So this Amplatzer duct occluder 2, which was introduced recently by the same company, the AGA, it has a lot of advantages, in my opinion, and also by using it. It has 2 discs, so the risk of embolization is nil, actually. It cannot embolize. There's no way it cannot embolize because it has 2 discs. The other advantage is that it goes through, there is no dilator. It goes through a sheath with no dilator because the sheath is tapered, so it crosses the PDA very easily, and it's very soft and low profile, so it can go through very small PDAs. It comes in diameters from 3 to 6 and in 2 lengths, and the delivery catheter is 4 or 5 French. And this is it's also made from the same as all AGA Amplatzer products, from 19-ol, but there is no fabric, and it comes in 8 sizes and a double disc. And it should sit in the PDA like this, 1 disc at the aortic end and 1 disc at the pulmonary end. The other advantage, it has many layers of closure of the PDA, so also residual shunt, it will be very minimal. And this is an example of patients, a very small PDA, another one with tiny PDA like the one I showed before. And we should do the measurements like this. The length is very important to decide which type of ADO2 we will use, the shorter one or the longer one. And actually the company gives you the instructions or the directions to which one you would use, and we will measure the pulmonary end as usual. So this is a very small PDA, 2.5 millimeter, but actually this particular patient, there is some pulmonary artery dilatation, which indicates maybe it was bigger before, or it is causing hemodynamic increased hemodynamic effect. None of these patients really had hemodynamic, were on medications, or had left side dilatation. And we can introduce the device from the pulmonary end, as we do with the ADO1, the first disc, the aortic disc, into the aorta, the constrictive part in the middle, and then the pulmonary disc in the pulmonary artery. And then you release it as usual, and here it is. It looks nice on lateral views. And you can also deploy this device from the aortic end. And this is very important because then you save the time of the arteriovenous loop you have to do with the ADO1. And so it's easy to go from the aortic end, and you can use 4 French catheter, not sheath, for very small PDA like this one. This PDA was a tubular type and very small at the end, could not cross from the pulmonary end. So we used this, we closed it from the aortic end. And actually the PDA was even long, so that the longer device did not reach the aortic end, and it crumbled in the PDA itself, but it was good enough to close this PDA. And this is the echo post procedure. You can see the 2 discs very clearly, and also here with color, again with the still picture. And this table just summarized the comparison between the coil group and the ADO2 group, and they are actually similar. There was non-significant difference in all the parameters, or the age, the weight, the angiographic diameter, the relation between the device and the PDA, the fluoroscopy time. Even with embolization, we had 2 patients in this group of coils. One embolized, was retrieved and done again with another coil, of course, and the other one was very small coil, which was embolized very distal. We could not retrieve it, so we just pushed it to a very small branch. And even with the embolization, there was no statistically was not significant. The LPA turbulence was noted also in one